Well, I get to sit down today with Dr. Mock, and we have done a podcast in the past together, but not in person. So
Yeah.
we're at the Fatona Super Symposium, and now we get to sit down and actually in person talk because there's a couple different things that we want to talk about. But I'm going to let you tell a little bit about yourself because you have a great history. Like, he's out of Michigan, but he has multiple offices in other states, and he has a lot of offices and a great businessman, in addition to deep diving into the science of sleep apnea, but aesthetics and hormone replacement therapy, wellness overall, and even longevity. We're talking today about all kinds of longevity and anti-aging
Yeah.
science and tricks you're doing. So,
Thank
but
you.
yeah.
So, what I want to talk about today, you were talking a lot about sexual health. And one of the things that brings up is testosterone for women.
Mm-hmm.
And there's a few attempts over the years to get testosterone approved by the FDA for women for sexual health. And each time it got turned down with the idea that testosterone might somehow be harmful or that women's sexual health might not be a clinically meaningful condition.
Mm-hmm.
And testosterone was first FDA approved for women in 1953 for metastatic breast cancer. And people are concerned that hormones might cause metastatic breast cancer, yet testosterone is approved for metastatic breast cancer. In fact, tamoxifen, which is a drug they use when people have breast cancer, estrogen receptor positive, is modeled off testosterone, but it doesn't work as well. However, testosterone was a generic drug. And I just want to go a little history over how we treated menopause in women, and then we can talk about other stuff related to testosterone. So, menopause, that cessation of having periods for a year or having your uterus removed, was treated like a mental illness back in the 40s and 50s. Then they started finding that ground-up sheep ovaries would relieve some of the symptoms of menopause. And then out came a drug called Premarin, which is based on the composition of a pregnant 5-year-old mare, Premarin. And that worked quite well. And there was a study in the late 80s called the PEPI trial, PEPI, where you use Premarin with progesterone, which is you have to use progesterone with Premarin. Otherwise, if you have a uterus, you may get uterine cancer because estrogen will cause your uterus to grow. And they found less all-cause mortality, particularly from cardiovascular. They seem to be very cardiovascular protective. And so then in the 80s and 90s, doctors started prescribing Premarin and Provera or progesterone to women in menopause at any age to protect them from heart disease. It became a standard of care. In fact, it was the biggest selling drug in the world. Wyeth Labs made Premarin. Prior to the newer synthetic forms of progesterone, we actually use natural progesterone, but then we assume that the synthetic version will be as good or better. So then in the late 90s, the world, WHI, wanted to figure out if should we study whether or not putting older women who are in menopause, who've never been on anything, on Prempro or Premarin would extend their life or not. And this is the Women's Health Initiative trial, WHI. And it was reported there was two large groups. Of course, they had a control and the active group. But it was Premarin and nothing if they had no uterus. And it was Premarin and Provera if they had a uterus. The idea is that you need estrogen alone. Estrogen can't go alone. When you're making it on your own, you're making other hormones. And they stopped the trial short in 2002 on the Premarin Provera arm, finding that there was a slight increased risk of breast cancer. And there was a concern that there might have been an increased risk of of cardiovascular disease, but wasn't clear. But they did stop it. And I was actually in San Francisco. I read it in I think it was USA Today. They were an infant newspaper at that time, and it said estrogen causes breast cancer. And in the study, they showed that there was 0.08% increase in breast cancer in women on Prem-Pro over nothing. And there you go. Estrogen causes breast cancer. Boom.
Headlines.
Yep. And
everywhere.
the doctors stopped prescribing Prem-Pro. They had women who had vasomotor symptoms, and it's like they're on their own. There's a big study called the AWARE trial, AWARE, and it showed something like 80% of women were immediately taken off their hormone with replacement of psychiatric drugs. Once again, we're back to psychiatric illness. 2 years later, out came the Premarin only arm. And interesting, the women in the Premarin only arm actually had less breast cancer than controls. Well, Premarin might be weakly suppressive of estrogen receptive cells of breast cancer. So now here we are years later, where we at and how does testosterone figure into it? Well, other countries were using testosterone as a primary drug for menopause because they never made the assumption that you needed estrogen. So if we look at our ovaries make, not ours, I don't have ovaries, but our women's ovaries make
Our gonadals,
testosterone
yeah.
20 times more than estrogen. And most of your estrogen comes from your native testosterone. And in Europe, Australia, it was commonplace to use testosterone replacement therapy, usually as a pellet, like a 100 milligram pellet, with or without estrogen, but typically with estrogen. They weren't seeing these increased risk of breast
And that's been
cancer.
going on since like the 60s.
Yes.
Internationally.
First approved in the 50s.
Okay.
Yeah. It was approved for women about the same time as men. So they didn't see this increased risk. So then doctors started thinking, what are we going to do about this? Can testosterone be suppressive? We know that testosterone is suppressive for breast cancer. It seems to be cardiac protective. It's not crystal clear. So doctors started prescribing bioidentical hormones at first, 03, 04. Suzanne Summers wrote a wonderful book called The Sexy Years and said, hey, look, maybe we're using synthetic drugs. That shouldn't be the case. I don't agree with that entirely. I think she's on the right track, but that wasn't it. That wasn't it. First off, the error in the Women's Health Initiative trial was the average age was about 70 years old, had never been on anything. When we look back now, we find that women who were started on Premarin, Provera, or Premarin within 10 years of menopause had a 40% reduction in heart attacks. 40% reduction. This was the biggest disservice to women's health care in history. Because we threw women into vasomotor symptoms, poor quality of life, because we were afraid we were going to give them breast cancer when it wasn't true. Secondly, we were afraid they were going to get heart disease. Wasn't true. However, if you take a woman that's been in menopause for 20 years, you can't start on a strong synthetic aggressive estrogen and progesterone. So that being said, that's true.
Well, it looks like the first 10 years after, when you can actually do some prevention, we weren't preventing, and then
We're
they were
preventing heart disease.
placing
Yeah.
on synthetic 10 years out, and they weren't symptomatic either.
They weren't symptomatic. Their symptoms were gone, and so they lost the benefit of the weight, of the cardiac protection, potentially other protections, bone protection.
Yeah.
So now we have drugs for bone health that they have problems. They cause some other issues. Now we have these thick bones that's still going to break. We were putting people on SSRIs and other drugs as if they're psychiatric problems.
Sleep medicines.
Letting them gain weight.
Anti-anxieties. Yeah.
So my history is I was in the cosmetic world just when it started. In fact, the word med spa didn't even exist in our state. I started our practice the year Botox got FDA approved for cosmetic indications, 03. And our women were looking for, I was having women's patients mostly, and they were willing to pay out of their pocket for stuff that wasn't covered. And I was looking for alternative treatments. I started using bioidentical estrogens, progesterones, and testosterones. And then we found we really couldn't get the dose of testosterone into a woman with topicals because it would grow hair on the skin and pellets. So pellets were already available in Europe. They were available in America, but not that common yet. So we started using pellet therapy. Then I started looking at the literature. Over about a decade, these things came through. So there was a Dr. Ruth Glazer in Dayton, Ohio, who's basically a breast cancer doctor.
I followed a lot of her stuff because she still is using testosterone pellets, even in treatment of breast cancer.
And she's really anti-estrogen. I don't agree with that part, but she's, because her bias is so much against, we have to allow women to get treatments. Anyways, the summary of her studies, about this, is that in her case series compared to the WHI trial, she sees a 70% reduction in breast cancer by using testosterone alone or testosterone with an estrogen blocker. Now I'm jumping forward now 20 years, is that recently studies from big companies, big chains like BioT or big organizations, they're finding that if you give a woman testosterone, in this case pellet, estrogen or not, you do not raise the incidence of breast cancer. There's still at least 40% reduction in breast cancer over normal, like norms that we have. So it kind of changes the thinking. So back in, say, late zeros and early teens, we were just using testosterone alone for women in menopause. We know it reduces all symptoms of menopause: bone health, sexual health, energy, sleep, cardiovascular. Well, cardiovascular, that was always questionable. And the studies have shown benefits, testosterone, cardiovascular, relaxation. There's no actual, what's the incidence of heart attack studies with testosterone. So during that time, we're realizing it's probably neutral or beneficial in cardiovascular disease, certainly beneficial for breast cancer protection, certainly beneficial for vasomotor symptoms, bone health, overall health, sexual health, skin health. But what about heart health? Well, then out comes the second arm of the Women's Health Initiative trial in the last 10 years. and several other studies showing that if you start estrogen within 6 or 10 years of menopause, you have significant reduction in cardiovascular events. And that's kind of led me to ease up on, we were not using estrogen years ago because there's so much political downplay. I started a woman on testosterone, estrogen, and progesterone. Her doctor would flip out, you're going to get breast cancer.
Mhm.
Well, you're on testosterone with blocks blood cancer. Well, they didn't know, so we just took it out of the mix.
So they
Now,
would scare patients.
they would scare patients. Yeah, they'd make them stop. So then they'd have to suffer and have increased risk of heart disease. Now I find, 10 years, 20 years later, that most doctors aren't aware of the Women's Health Initiative trial because we've realized that that's not a useful trial for telling whether or not a woman in menopause should go on HRT. In fact, it wasn't designed to tell if a woman should go on menopause when she was on HRT. It was designed to answer the question, should we put all women, regardless of menopausal state, who have been on nothing, on HRT? The answer is probably not, maybe not. Maybe something else would be effective, but not on Prempro. That answers that clearly. But women within 10 years.
They knew that there was symptomatic improvement. They were questioning the safety.
Stroke of safety. And then, like you were saying, in some cases, women had no symptoms because they're maybe 75 years old. They'd been through it. And it'd be hard to measure improvements at that point.
And it's also hard to commit them to a treatment. And they were allowed to also withdraw and change, so it wasn't a great study, but yeah.
It wasn't a great study, but it was one that led to a lot of paranoia. So going back to how are we approaching this? So first off, if you look at your blood work that you get from your doctor's office, it lists out estrogen and testosterone level and all your blood tests. But when doctors are looking at blood work, they want to see 1 or 2 digits, maybe 3. And they use different units of measure, nanograms per deciliter, picograms per milliliter. And so they manipulate the estrogen and testosterone, where you might have an estrogen of 100 or say 50 and testosterone of 90. It actually would be 50 to 900. It's a 10x. You have to add a 0 to testosterone to make it equal estrogen, or subtract the 0 off the estrogen. You have 20 times more testosterone and estrogen.
Most abundant.
Yeah, so our normal dosing is testosterone 1 milligram per pound, and then roughly 6 milligrams of estrogen for most women. If they need more than that, they'll usually aromatize it from their testosterone. And I would argue that the testosterone alone does aromatize estrogen, and it certainly does, but not in all women. And we don't have the for sure cardiovascular protection that we do with adding estrogen in. That's been and then adding progesterone in, and that's been our approach. Studies have shown that right now we have a lot of use of GLP-1 agonists for weight. So there's a study in Sweden where they took women in their 50s that were perimenopausal. They put them on testosterone or placebo. Well, perimenopausal women, as you know, the most common chief complaint is they gain weight. 6 months later, the placebo patients gained about 5 pounds, and the testosterone patients lost about 5. In spite of their bones probably got a lot more dense. So there is a beneficial effect on weight. It's not like the weight's going to fall off you. It's beneficial.
Yeah, not an automatic treatment, but building more muscle, better recovery.
Their lean mass will get better as a percentage of their weight, and their fat, generally fat mass decreases. We have breast cancer protection, which I think is huge. That was really my main focus. The cardiovascular benefit was not crystal clear, but it appeared to be trended towards, however, adding estrogen in does. And even in our business with skin health, the skin responds well to estrogen, just like vaginal moisture. The face looks brighter with estrogen. At the pregnancy glow,
I was going to
that's from estriol.
That's what when we put estriol in a product, it's all about the glow of pregnancy. That's what
you can spread that stuff everywhere.
Yes,
and it doesn't turn into anything else. So estradiol, which is your active estrogen, can turn into other estrogens. So we don't want to overdo that. You get breast tenderness and swelling, but estriol, it's going in your skin or you're urinating it out.
Yeah, and estrogen not going back to. But you know what I think is so important about this, and I do want to get this, like you were there when the World Health Initiative study came out. So you saw, and I saw all the doctors prescribing Provera and Premarin.
Right.
And then it suddenly stopped. Obviously the breast cancer incidence, just from a common sense standpoint, it has not went down. It's continued to increase. So obviously multifactorial. So you have those doctors that were scared and have scared patients. But now you're saying that there's a younger group of docs that really aren't aware of that, but they still don't have the information that they need to not scare patients or to even offer it to patients. And so that's kind of the younger group of docs that are out now and treating.
What they're kind of being directed to by their colleges is when women go into menopause, go ahead and treat them with an estrogen and a progestin, and for a period of time. And there's no good evidence to say that if a woman goes on estrogen forever, that she'll extend her life. There is decent evidence that if women go on hormone replacement therapy for a decade, they'll get about 3 years of extended lifespan. That in itself is good enough. Studies will show us down the road, should women go on forever? My bias is towards they should, because there's not a point where they're going to want to have brittle bones, want to have less sex, want to have less energy, want to get heavier, and want to have a risk for breast cancer. But we just, quite frankly, don't know until we scientifically prove it, which might never happen. So some things have to be based on evidence-based medicine versus solid, sound science.
Well, and we're always behind with studies, and a lot of the studies haven't really evaluated women. We haven't evaluated them with bioidenticals. It's hard to, find studies that are strongly in support of bioidentical versus synthetic, but what we're doing is different. But I think the key is that when you're looking at it, there's still not a lot of, you're still seeing a lot of patients that are coming to your offices because they're not getting solutions, and the primary care doctors and gynecologists still aren't really testing, right? All the hormones, even testosterone, because I find that even if they put them on something, it's usually an estrogen. You can kind of tell if something's done right or not, if they're on the progesterone, capsule. So if you just want to talk a little bit about, that complement of like progesterone to being there, it's not just a uterine effect because it's sleep and it's mood and then estrogen, obviously once they hit menopause, but they're not even really looking at testosterone.
They don't, and I think this is really important to understand, and this is why I'm leery about getting a testosterone level after somebody's on it, because there's a pharmacologic and a physiologic blood level. Let's say a woman's normal level when she's 35 years old is 50 to 90, let's say the units. If you put her on, and she's in menopause now, it's down to 20. If we put her on testosterone, we need to see a level of about 250 to equivalent of a free testosterone when she was 35. We can't measure free testosterone. If you order a free testosterone, it's actually a calculation. They can't account for the sex hormone binding globulin and albumin sucking it up. There's a study done by Dr. Glazer again, where she looked at what level do women feel normal? It's 250 to 300. And then that doctor freaks out. That's like, it's higher than normal. So I generally don't test it afterwards because that freaks people out. The saliva tests do the same thing. It accumulates in your saliva. But back to your point, progesterone has an effect on virtually every organ in your body. What's interesting is we look at the synthetic progesterone, Prevera, which we use as a birth control pill or as something to treat abnormal bleeding or for menopause. It has a positive effect on the uterus, arguably stronger than progesterone, but a negative effect on every other organ. And this is what happens with key switches and hormones. These hormones are so tiny.
Correct, yes.
They fit in there. It has a negative effect on bone, progesterone positive. Progesterone is breast cancer protective. So if somebody has estrogen and progesterone receptor positive breast cancer, progesterone is actually anti-cancer.
Correct.
And estrogen is pro-cancer.
Yeah.
Progesterone applied to lumpy breasts makes them softer.
Yes.
Progesterone has a positive effect on the mood, is a positive effect on blood vessels. So these are not one target hormones. Correct. Testosterone is rarely checked because family doctors don't have the ability to write a prescription and you go to Walgreens to pick up testosterone. It's got to be compounded. We use a outsourced compounding facility that manufactures testosterone. They're called a 503B, so they're allowed to make it in mass quantities so that we have the pellets in our office. The pellets are superior to injectables or creams. I know there's a lot of disagreement with that, but probably that's what 90% of doctors that practice this feel. The injectables, you really can't get dosing right, and tends to be a lot of peaks and valleys. Yeah. Whereas
and fluctuations, peaks and valleys, some more in the way of side effects. And I don't find that I ever got a level with a, topical cream to be adequate or steady state. And no one ever felt better on that. But pellets and, again, there's no FDA approved, which you said early on, and we kind of flew past, but there's no FDA approved product for testosterone in women in the US. So we're applying male products to women, and it's really just topical because everything else is compounded, which is fine.
Well, there's Testopel, which is a pellet that's FDA approved. It's a 75 milligram pellet, and it's not approved for women. You're right, but the
is it approved here in the US?
Yes. Okay. So the FDA approved testosterone in women in the 50s. And things were different back then. We didn't have big pharma. So since there's no big pharma with that drug, they'd have to actually get a new delivery system or something new to get a new drug approval, but it is FDA approved.
Yeah.
Testopel is approved for men. It's not, they only allow you to get like 200 milligrams for
Yeah.
men, which is not enough. And it's like a lot of things, we're not contemporaneous doing this. And like you say, it'd normally be a topical cream. There was an attempt by Johnson & Johnson to get a patch approved, and they were getting an approval on their patch, not on testosterone. It's already approved. And they went through their clinical studies, and they showed this helped female sexual hypoactive disorder, which there's other drugs approved for now. And the FDA had a group of men, no women on the board, and said that first off, they don't think they want to subject the women to the risk of heart disease from testosterone just to make them have sex more. Well, there is zero evidence that testosterone causes heart disease. In fact, in men, the largest study is 83,000 men followed for 6 years, and it was done at the VA. 2016 was published. In men that had low T, if they were not given testosterone replacement, they were twice as likely to be dead over the next 6 years. Twice, double. And the FDA's approach was, well, we don't know that testosterone doesn't cause heart disease. It's unequivocal. It's cardiac protective in men and women.
Yeah, no, there's a lot of misinformation about that, but I think that like women are looking for solutions. They're more proactive than we are in the medical community about providing those solutions. But I think that informed consent, like just having a conversation with them, but there is like a recent study again that kind of looked at cardiovascular risk with testosterone in women, but it's just there's very few studies out that actually look at women, like you said. Largest study was men, but even that showed improvement in everything across the board: insulin sensitivity, inflammatory markers, lipid panels, cardiovascular risk, all cause mortality, all of that. It was just small.
What leads to this bias that testosterone causes cardiovascular disease is one condition called PCOS, polycystic ovarian disease syndrome. And they have very high androgen levels. They also typically are obese. They've got insulin resistance symptoms, and they have higher incidence of cardiovascular disease. So that's the assumption. Since that's high, therefore, the opposite has been shown. Additionally, estrogen is hugely cardiovascular protective. So in my bias is towards adding estrogen to give additional cardiovascular protection, but there's no evidence that testosterone increases a woman's incidence of heart disease. And there's subtle evidence showing it decreases it, but not as strongly as estrogen. Both are very bone supportive. Both are very good for sexual health. Both are very good for energy. Both are promotion of weight maintenance, where weight gain during menopause is very common.
Yeah. Well, and I think the big thing is that addressing it comprehensively, even offering those solutions and pellets and looking at, because I think one big thing that I still have an issue with, and I'm sure you do too, is that guidelines are, again, supported sometimes by those societies are supported by pharmaceutical companies. If you go way back to who's on those, those societies and who's writing guidelines, a lot of times they're not treating women. So it's not women or specialists or experts, and it's an expert opinion. But also right now, as it exists, it's really only testosterone use for women with a low sex drive, yet in references in those guidelines, it shows that it improves more than just sex drive. It's arousal, it's frequency, it's sexual satisfaction. And so I think letting women decide, since there isn't some strong support for it causing any, breast cancer isn't to increase cardiovascular risk. Yeah, maybe we haven't assessed it fully, but it doesn't show it to be a high risk. So do you think that those guidelines will soon change, or the FDA might eventually approve a product for women? Do you see that coming anytime soon?
It will happen.
Okay.
What's happened is that big pharma needs to control healthcare in America. And when I started doing this, there was a handful of us that show up at a meeting and talk about using bioidentical hormones. In every city, there's a dozen doctors doing this, and they're buying compounded products, and big pharma wants a piece of this action. Plus, we have data, already the preliminary study has been done. These women are healthier, they're having less disease. So I think a big pharma company realized this is a multi-billion-dollar opportunity for them, and that's going to happen. And it'll happen probably within the next decade.
Okay.
So right now we have alternatives available.
Yeah. So, well, let's hopefully we get there then.
Yeah.
It didn't seem like we were changing much. They're still kind of scaring, and they don't give specifics about guidelines and what levels you need to go to. And I think that Glasser has probably the most data out on at least testosterone in women, which is, what we're talking about. And we're both treating women with testosterone with great effects. So, you can minimize side effects. You can manage those. Women tend
quite
to be
frankly, I've
much
been doing this
happier.
20 years. I'm not seeing side effects.
Yeah.
We were using creams, we were.
Hmm.
But the pellets just seem to set it and forget it. And sometimes people decide that they're not going anymore just because it's a cost issue. But we're not seeing side effects.
Yeah.
Maybe sometimes they need a little bit more,
Yeah.
maybe a little bit less, but like negligible.
Yeah. Well, and that's why I love talking with docs like you that have actually were doing the hormone replacement when the transition happened. So you have 20 years of experience
Right.
where I've been doing it for 5. And so when I talk to physicians with the experience you have, they're so helpful at the information that they have like that. And we hardly have anything in the way of side effects. If we do, it's easily managed and it's not always test.
Right.
It can be related to something else. But yeah, so you're seeing though that women are happy. I think
Absolutely.
that's the key, is that women are happier. Everything we complain about, the sleep, the mood, the lack of sex drive, the weight gain, the body composition changes, all of that,
We want
are,
healthy,
yeah.
happy patients.
Yeah, yeah. And happy sex life is a happy life for all, right?
That's right.
So, well, what we were doing is we were sitting down in between some talks, and he was speaking, and then I'm speaking. That's why I'm looking at my watch every once in a while to get to a room. But anyhow, I'm so glad we took time to talk about this topic, testosterone in women, and you have so much experience in the history. That's stuff I didn't even know, going back to the metastatic breast cancer and testosterone use for that. So I'm going to look into that.
All right.
Yeah.
Thank you very much.
Yeah. Well, so thank you so much. And we'll do another one based on, I would like to talk about sleep apnea sometime with you again, because you are, pushing forward the treatment, the innovation treatments on that, and innovative treatments. So there's some traditional ones that, go over well with some patients, but not all, but it does need to be treated. And so we need to sit down one more time to talk about
Sounds great.
some innovative treatments that you have for that. So, all right. Well, thank you so much for being here, and we'll do it again.